Good evening, everybody. So we start with the first satellite symposium. This is a topic on comprehensive genomic profiling in lung cancer. These are my disclosures. I'm being contracted for this particular presentation by Roche. And if you like to have a look at how the presentation is going to be, there will be a brief overview and epidemiology, the molecular characteristics of lung cancer briefly, the added clinical value in using CGP for the treatment of lung cancer, the clinical value of liquid biopsy in non-small cell lung cancer,
Hello, excuse me. Please be silent. Okay. Continue, Dr. Goswami.
new treatment options in non-small cell lung cancer driven by biomarkers and genomic signatures. I would avoid the case supporting the use of CGP to detect both common and rare driver mutations because otherwise it's going to be a little prolonged. Then the guidelines, a few guidelines, and then the key messages for this particular talk. Now, overview and epidemiology. Cancer treatment options have increased in recent decades, as you all know, ever since from radiation oncology to chemotherapy, surgery. I'm leaving aside because that's an age-old treatment. The first targeted therapy approved, and now the era of personalized combination therapies. So now it's never now one drug fits all treatment approach in cancer histology. It is a personalized treatment based on comprehensive knowledge of cancer patients. So lung cancer is the leading cause of cancer death worldwide, and as you all know that this is one of the most mutagenic tumors because lung cancer, the number of mutations which is discovered in lung cancer is not seen in any other cancers. And the declines in lung cancer mortality over the period of time have accelerated in the past decade, spurring the largest ever single year drop in overall cancer mortality of 2 to 2.2% from 2016 to 2017. So that's another important. And the reason for that is most of the lung cancers now are treated on a personalized treatment approach. So understanding different histological types of lung cancer and their prevalence, as we all know, 80 to 85% is non-small cell lung cancer divided between a large section of adenocarcinoma, squamous, and large cell, and of course, 15% of small cell lung cancer. The guideline highlights the requirement of broad molecular testing techniques to support therapy selection, and as you know, it's EGFR, BRAF, KRAS, HER2/neu, MET amplification or MET skipping mutation, HER2/neu, then ALK, ROS1 mutation, etc., etc. And if you look at all the methodology of getting this looked into, either you can do it in a sequencing pattern with Sanger sequence and IHC and FISH technology, or you can do it in a broad-based NGS panel. The advantages of NGS panel is that it can be done very quickly, and more or less all the guideline factors, including the ASCO educational book, the CAP, the International Association of Study of Lung Cancer, ESMO, etc., advocate this. So biomarker-based therapeutic approaches are associated with improved clinical efficacy in lung cancer. There has been an improvement in overall survival, progression-free survival, and first-line treatment response rate as well as second-line treatment response rate. And if you look at the two groups, those who are biomarker-selected targeted therapies and those who have undergone traditional therapy approach, definitely the biomarker-selected targeted therapies do definitely better. So molecular characteristics of lung cancer, our understanding of the genomic landscape of lung cancer is continuously growing. What we knew on 2004 and what we know now is enormously different, and there has been a huge number of mutations discovered, some common mutations and some rare mutations, and if you combine all the rare mutations, they are not so uncommon. So it's a huge ask. And if you look at the list of the drugs which are there given over there, if you can actually see that those in the dark letters are those are approved drugs, and those with the orange letters are in the pipeline. So you can understand the amount of research work being done and the amount of drugs being developed. Some of those drugs, it becomes difficult to pronounce as well because they are so difficult to memorize and so difficult to remember. But these are what the situation is like. So this is the advanced diagnostics informed therapy selection in lung cancer, and this is the entire repertoire of drugs available. The blue ones are those who are already approved and in the market, and the orange ones are which are being investigated at this point of time. So the added clinical value in using CGP for the treatment of lung cancer. Now what is CGP? Everybody talks about CGP. The actual word of CGP is comprehensive genomic profiling. And I tell either it is customized genomic profiling because we cannot do everything for everybody, or it's a confusional genomic profiling. You get confused with all the molecular, you get a foundation one report this big. I don't know whether you have the time to go through all those things and look at the highlighting part of it. But anyway, CGP is here to stay, whether it is confusing or whether it is customized, but comprehensive genomic panelling in certain situations is extremely important, like looking at treatment of carcinoma of unknown primary, looking at treatment of recurrent resistant types of tumor, where we do like to look at something beyond conventional treatment, and of course non-small cell lung cancer, where there are so many mutations available and so many drugs which address different mutations. And if you want to do every single mutation at different point of time, the prolongation of the turnaround time of the test is huge. The tissue becomes a big issue because you cannot get so much of tissue, and so comprehensive genomic profiling is the way forward. If you look at the additional value, I'll just give a brief summary of these slides. EGFR. Not all EGFR mutations are detected on standard test. If you do a Sanger sequence or if you do an immunohistochemistry, you cannot detect everything. But if you do an NGS, you would find more EGFR mutations, and if you target them with the appropriate drug, you will see responses. So that is what is said in this particular slide. Similarly, there are other tests done of where if you do CGP for looking for EGFR mutations, you will find more EGFR mutated lung cancer patients beyond what you see in standard tests. And naturally, more patients can avail targeted therapy. And you know in general that if you treat EGFR mutated patients and give chemotherapy like a EGFR wild type, you are going to get poor results. So as a clinician, our duty is to see and find out those mutations, and the best way forward is doing a next generation sequencing. Similarly is the case of ALK, because ALK also is one drug, and ALK mutated non-small cell lung cancer is one lung cancer where sequential therapy with multiple ALK inhibiting agent has got the median overall survival of ALK positive advanced non-small cell lung cancer to almost 5 years. So it's a fantastic result. So I think this is an important aspect. Comprehensive genomic profiling shows clinical utility in real world practice as well. If you look at it, most of the people are now switching to CGP or NGS platform, especially an RNA-based NGS platform, because that's where you detect the maximum number of mutations. So in summary of this part of the talk, that immunohistocytochemistry and CGP are both important tools in the management of lung cancer and may be used complementary, but at the same time one must understand that standard methodology like immunohistocytochemistry or FISH or Sanger sequence has its limitations on tissue requirement and as well as turnaround time, whereas NGS, even in small tissues, you can do next generation sequencing and the turnaround time is very quick. The clinical value of liquid biopsy, because lung is another disease where you may not get tissue all the time, especially in recurrent lung cancers, you might not be able to get tissues all the time. So in this sort of a situation, liquid biopsy is an important aspect where you can do all these tests and they can be corroborated with tissue biopsy very well in looking at all this next generation sequencing associated mutation studies. So liquid biopsy versus tissue biopsy is very well corroborated at this point of time, and all major clinical trials you will find that there is an exploratory arm of liquid biopsy where the same mutations are looked into from the blood, and they are well corroborated with the tissue. The other thing is low tumor burden limits capacity to detect early stage lung cancer, and there ctDNA is an important aspect. The earlier the stage, the chances of detecting the tumor on ctDNA, circulating tumor DNA, is less, and so is also the tissue. So that's why I think these things are coming into play. Circulating tumor DNA analysis is starting to provide clinically relevant information at various stages along the patient's journey, though it is not an acceptable tool in early diagnosis or prognostically and initial therapy selection methodology or surveillance monitoring, but it is definitely an important tool and established tool in the selection of further lines of therapy or in advanced cancer. Liquid biopsy in non-small cell lung cancer is already present, and it has a very near future. So right now the treatment selection for therapy is based on actionable mutations, and later on I think personalized for monitoring recurrence and looking at circulatory tumor DNA and possibility of minimal residual disease, looking at minimal residual disease, especially after successful resection of early lung cancer and also after chemoradiation of stage 3 lung cancer, looking at MRD to see whether we need to give them immuno-oncology or not. So guidelines are recognizing the usefulness of liquid biopsy for lung cancer at time of initial diagnosis in all patients who need tumor molecular profiling, if a patient is medically unfit for invasive tissue sampling, or if there is insufficient tissue for molecular analysis, and of course at disease progression. Liquid biopsy can complement tissue-based profiling, as I have already said, and there are multiple studies to show that they go hand in hand at looking from tissue or looking from blood samples. Prevalence of genomic alterations in the first-line setting of liquid versus tissue is similar. This is the BFAST trial, which looked at this, and it was found that they complement each other very well when you look at the same mutations, whether from tissue or archival tissue or from blood sample. So be it ALK, be it RET mutations, be it tumor mutational burden, be it ROS1, and be it EGFR. Tumor mutational burden, I'll come to later on, becomes an important tool because when immuno-oncology is such a well-established molecule in lung cancer, it is not always PD-L1 which decides whether the patient can get immunotherapy or not. So tumor mutational burden comes in as well. So predictive value of liquid biopsy on making treatment decision is huge, and this particular trial demonstrates the clinical utility of blood-based NGS to inform use of various drugs like alectinib, or like the other drugs which I'll come into. Alectinib, of course, for ALK-positive advanced lung cancer. ctDNA levels before treatment predict survival in non-small cell lung cancer treated in EGFR TKI, that if they have still ctDNA after treatment, you can say whether their progression-free survival is going to be better or not, or overall survival is going to be better or not. So that makes a sense. Prognostic value of baseline liquid biopsy, this is also evident in the real life setting. Look at many of these trials. These are Lux Lung series of trials, the URTRAX trial, the Fast Track trial. Every trial has a complementary arm of exploratory arm of analyzing blood samples for mutational analysis. Liquid biopsies have the potential to measure the success of therapies, allowing to adjust them accordingly. As I said, that you can do it after surgery or you can do it after concurrent chemoradiation. Liquid biopsies can provide prognostic insights along the patient journey. This is from the ALEX trial, where alectinib was the drug of choice, where it has shown that tissue liquid biopsy helps in identifying these patients who can benefit from the drug. The role of MRD in lung cancer treatment, as I was speaking just a few moments back, that looking at MRD for deciding adjuvant or no adjuvant therapy in post-resection lung cancer treatment. You can look at the ctDNA, and if the ctDNA is negative or the cell-free DNA is negative, you can avoid giving adjuvant therapy, or you can give adjuvant therapy in those who have ctDNA positive. And thereby you can differentiate who actually benefits from adjuvant therapy and who doesn't. ctDNA and MRD after chemoradiotherapy, as I said, this was from the Pacific trial where durvalumab was the drug, and you can understand that if you have a ctDNA positive, they benefit from immunotherapy. If it is negative, they do not benefit from immunotherapy. MRD for deciding adjuvant chemotherapy plus immune checkpoint inhibitors. Again, this is another thing where it has been found that immune checkpoint inhibitor as a maintenance is beneficial if you have circulating tumor DNA after definitive treatment of lung cancer. New treatment options in non-small cell lung cancer driven by biomarkers and genomic signatures like MET-XL alterations, skipping mutations. Capmatinib is one of those drugs which has been shown with liquid biopsy. Same is with the other drug, quizartinib, in MET skipping mutations. The same is with tepotinib, another MET skipping mutation in a molecule where it has been found to be corroboratory with liquid biopsies. RET alterations has been looked into with newer drugs like sulfatinib. This is also being used, expressed in clinical trials. Also by other drugs like pralsetinib. I said these are difficult drugs to pronounce, but these are new molecules which are coming in for RET mutations. EGFR mutations, we already have the data from the FLORA and the other trials with osimertinib. And then the KRAS mutations which are being looked into for newer molecules, and they are also being looked into with ctDNA from blood samples. Genomic signatures and immunotherapy, that's another important one. As I was saying, PDL1 is the standard way of looking into the CPS score and the TPS score to look for response to immunotherapy. But other than this, there are patients who do benefit from immunotherapy either with a high MSI or with a TMB. And immunogenic tumors have a high mutational burden, and if you have a high TMB, they are likely to benefit with immuno-oncology. As of now, the indication is PDL1 positivity, but soon I think this is going to change, and higher TMB is going to become an indication for using immuno-oncology drugs in this sort of a treatment. So predictive biomarkers for response to immunotherapy are highly sought after at this point of time. So PDL1 is one, but I think TMB is going to be an important aspect, and you can only get TMB in an NGS and where you can get the tumor mutational burden. Comprehensive genomic profiling accurately estimates the tumor mutational burden and which may be associated with response to immunotherapy, as I have said, and these are the data in support of that. Well, it is already proved for atezolizumab. It is also proved for durvalumab. So these are the two immune checkpoint inhibitors where it has been found. It has also been proved to be efficiently corroboratory in a combination of pembrolizumab with chemotherapy for non-small cell lung cancer, where plasma TMB is the key thing which has been looked into for deciding on patients who go for chemotherapy plus minus immunotherapy. So coming to the guidelines, the clinical guidelines do not always match clinical practice, but we do have to make a combination somewhere. So as I said in my earlier slides, NGS is one platform where you can look at all sorts of mutation, whether they are looked into as point mutations or small alleles, or they are looked into as copy number alterations, or they are looked into as rearrangements. So you can look at all these things. Instead of looking at them separately, you can look at it as an NGS platform mostly on an RNA based, and most of the pathological guidelines are approving this. Foundation 1 CDX includes all NCCN recommended genomic alterations and detects alterations missed by other approaches. Now, Foundation 1 CDX can be tissue based, it can be blood based, so both are important, and they have a very good correlation amongst themselves. So Foundation 1 CDX and liquid CDX is valid for all solid tumor types. For Foundation 1 CDX is done from the frozen samples, where the liquid biopsy is done from the peripheral whole blood, and the ctDNA is looked into. The number of genes include more than 300 genes. Genomic signatures and biomarkers like MSI, TMB, loss of heterozygosity are looked into. MSI and blood tumor mutation burden is also looked into, and it is understood now it is not the only mutation which is being looked into. The downstream pathways are also looked into for effectivity of the drug, and NGS also looked at these downstream mutation pathways. So it's a companion diagnostics, FDA approved CDX for 20 plus targeted therapies, and the liquid biopsy for 7 targeted therapies at this point of time. So Foundation 1 CDX and Foundation 1 liquid CDX are FDA approved along with various therapies in non-small cell lung cancer. So many drugs are approved. It's a very expensive test. It costs around 2,70,000, but Roche gives you a lot of discounts, cashbacks for patients. And if you have been using immunotherapy for a particular patient, especially atezolizumab, they do it free of cost. So I think this is one area where there are other NGS platforms which are coming up, which are less expensive than Foundation 1. They are also looking at almost this many gene mutations, but this is one validated at this point of time. And the key messages are that guidelines recommend broad molecular testing using multi-gene NGS assays. CGP or comprehensive genomic profiling uncovers both common and rare driver alterations, potentially undetected by standard of care testing in non-small cell lung cancer and impacts clinical decision making. CGP can identify patients who would benefit from targeted therapy, immunotherapy, and clinical trials as well. And liquid biopsy-based CGP is minimally invasive alternative when tissue is not available and has the potential, and especially in lung, some of these tissues are inaccessible, so you cannot actually get a tissue biopsy. So this is it. So if you want to learn more, you can visit the websites, and this is what we say that doing now what patient needs next. So this is what the future of molecular genetics is going to be. Thank you very, very much.